everyone. Welcome to another Nephrology VMR. We're very, very happy to be here again with Dr. Rich. Hello, Dr. Rich. Would you like to say hello?
Hello, everybody. Glad to be back. And hopefully, no, not hopefully, we are going to have another great session. So we got great people here. So let's do it.
Pretty sure we will. And today we have a volunteer discussant. Hans, would you like to say hello, Hans?
Yes, hello from Huntsville, Muskoka, and we got 30 centimeters of snow yesterday.
Really?
I think the staff, you need more.
Hope you're staying warm, friend. And last but not least, Heman. She's presenting today a case. Would you like to say hello, dear He?
Yes, it's really honor to present case to Dr. Rich and Hans. I'm very excited, and my case will be interesting.
Awesome. Whenever we're ready today, Paris and Sasan will be on the whiteboard. So whenever you're ready, friends.
Yas, can you please make me co-host so I can share my screen?
Yeah, of course. So sorry, friend. It's already done. Whenever you're ready, He.
Okay, so CHIP complaint is progressive abdominal distension, dyspnea, oliguria, and fatigue. This is the end of first aliquot.
When I've done this in the past, we've always gone back and forth. So let me start, and then Hans, you can then finish, and then with the next aliquot, you can start, and then I'll finish. What was the chief complaint? You said abdominal distension. What else?
Progressive abdominal distension, dyspnea, oliguria, and fatigue.
Okay. So, let's just kind of start with the focal point being abdominal distension. Certainly, again, when you think about abdominal distension, again, looking at the fluid medium or the medium of the abdomen, is this fluid? Is this something like ascites? Is this something like, is the person having like a bowel obstruction, or is this gas? Is there like an ileus or a bowel distension? Again, given the nature of what we're going to be talking about, it's likely more fluid related. So thinking about something like ascites, and if we're thinking about ascites, would this be something, high albumin gradient or low albumin gradient? I don't know if this is a male or a female, but certainly thinking about things like heart failure being related to this, either as a component of the ascites or the ascites itself, causing such abdominal distension, it's interfering with the diaphragmatic excursion, causing shortness of breath. There can also be physical disability or physical debility contributing to fatigue, depending on the underlying cause, like, for example, cirrhosis or cardiac cachexia. Could be other concomitant factors like anemia, decreased urine output. I'm going to make the assumption that there is some aspect of kidney being involved. Again, this being a nephrology morning report, and certainly, differentials, making the assumption that we're dealing with ascites could either be, when I think about ascites and renal disease, if that's where we're going with this, and I'll stop after this, would be pre-renal azotemia, ATN, hepatorenal, or increased intra-abdominal pressure causing pressure on the renal venous vasculature, which, you can have increased abdominal pressure causing decreased urine output. And we'll kind of start from there. I'd like to know the time course of this as well, whether this was over a couple of days, a couple of weeks, or the time course of the presentation. Likely he had worsening abdominal distension and then decreased urine output. So I suspect we may be talking about something like hepatorenal syndrome. Go ahead. I'm sorry. Go ahead, Hans.
Yes, and with the time course, because the patient has already abdominal distension, and we assume, this being nephrology, that it could be fluid, that is maybe ascites, I want to add the possibility that this could actually be maybe more chronic than acute, because it takes time for fluid to accumulate if it is owing to the heart or the kidney. So let's see what the following aliquots will bring.
Amazing discussion. Oh, yeah. Do you have a question? Not finished yet?
Actually,
No, that was Cody. Sorry. Go ahead.
Okay. All right. Am I ready to go? Second outcut? Okay. All right. 52-year-old man with a known cirrhosis, child B, male 30, and a refractory ascites, present with a progressive abdominal distension, shortness of breath, and fatigue. He reported reduced urine output, difficulty breathing when lying flat, and increasing confusion over the past few days. Symptoms worsened despite recent paracentesis and ongoing diuretics. He denies fever, chest pain, hemoptysis or hematemesis, no recent sick contact or travel, no NSAID or contrast dye use. Okay, and this is a second allocate end.
Hans, if you want to start, and then I'll finish up after.
so we got the information that the patient has a liver disease, that he has cirrhosis, and that over time he developed the complication of ascites. So my assumption would be, as mentioned earlier, that there is a possibility for hepatorenal disease, that is a dilation of the splanchnic vasculature, which causes a kind of pre-renal AKI or kidney injury. That would be my first thought at this.
Okay. Yeah. So let's talk about certain things. You said first, I'll actually see better without the glasses. He has a MELD score of 30. So if you think about, where this patient is, MELD scores range from 0 to 40. And anyone who has a MELD score more than 20, certainly it's at that point where you begin, usually around a MELD score of 25, where the person goes for evaluation for a liver transplant. MELD score looks at different things. It also looks at criteria. It's actually MELD sodium score that also looks at, what the creatinine level is and if the person is on hemodialysis. In someone who is, if you're seeing somebody with, who is requiring more frequent paracentesis, it's because they're getting worsening liver damage. They're getting worsening portal hypertension. One can begin to start see ascites when they have portal venous pressures greater than 30 millimeters of mercury. And there's different ways to measure that. If you on a textbook, you'll get something you can measure like an veno-occlusive gradient, and there's a specialized way in which to measure that. Most of the time, you're seeing more Dopplers that can be used to measure portal venous pressures. But certainly, this is in the setting of someone who's developing worsening liver disease, whose liver is getting more symptomatic. He's refractory to diuretics. He likely has worsening kidney function. And, I'm going to say that he likely has suspected hepatorenal syndrome, in this setting of cirrhosis. And if you think about the pathogenesis of hepatorenal syndrome, basically what happens, just to expand a little bit what Hans said, and I'll be mindful of the time as well, you have splanchnic vasodilatation. And, the splanchnic vasodilatation, you have increased production in the endothelium of nitrous oxide. And what happens is, from a splanchnic point of view, that, the goal is to try to, that's a reflex, from increased splanchnic pressures. But then what happens is you get renal vasoconstriction. So the more of the vasodilatory aspect, you get more renal vasoconstriction, and it makes the severity of the AKI even worse. There's new nomenclature now. It used to be called type 1 and type 2 hepatorenal syndrome. Now it's hepatorenal syndrome acute kidney injury, which is worsening kidney function over days to weeks, whereas hepatorenal syndrome chronic kidney disease is what we used to be referred to as type 2 hepatorenal syndrome, which is type 2 over weeks to months. Again, certainly before again, there's always a history here of more frequent paracentesis. Other things to rule out, there would likely be a cause of AKI. And, first would be pre-renal azotemia, either giving a volume challenge or albumin to see if you get an increase in urine output, increase abdominal pressure. In some patients, when you do a therapeutic paracentesis, you lower intra-abdominal pressure, you can begin to see increase in urine output. A patient will often report a history of that. Given that this person has refractory ascites, that's less likely to be the case. And of course, ATN versus hepatorenal syndrome are overlapping diagnostics, which can be clinically look the same with low urine sodiums. We'll talk about that next aliquot. I'm sorry, Hemon, I went off the deep end again. My apologies. Go ahead.
Okay, so I'm going to give you more information.
I'll be right
Okay,
back.
Yeah, do you have any question?
I have to find my dog. Sorry, I'm right.
Okay, all right. Okay. All right, so past medical history: cirrhosis, child B, male 30, refractory ascites for last 6 months despite of tapping is not getting better. And EGD was recently done and no varices. Meds are spironolactone and furosemide. Family history none, social history none, health-related behavior, alcohol, heavy drinking, allergies is none. And I'm going to go to the physical exam. Vital sign, heart rate is 90, respiratory rate 23, BP is 110/70, SpO2 is 96%, HENT, scleroicterus, no lymphadenopathy, CV, no JVD, regular rate and rhythm, no murmurs, pulmonary decreased breath sound at bilateral basis, no rolls, abdomen markedly distend, positive fluid wave, shifting dullness, diffuse tenderness without rebound, neuroalar but mildly confused, asterixis, extremity, swelling of lower limb, bilateral pulse, a skin spider angioma on upper chest. Okay, this is third aliquot. And
all right, I'll start with this one, and then Hans, if you can go second. I'd like to first know his doses of spironolactone and furosemide. Usually when someone is first diagnosed with ascites, usually starting the standard way of approaching this is like 100 of aldactone and 40 of Lasix. And when you look at the pathophysiology of like hepatorenal syndrome, or even just if we can just separate out the pathophysiology of ascites in general and why aldactone is usually given initially, they've actually done trials when they've looked at what is better, giving Lasix first, giving aldactone first, or giving the two together. And again, initially you have an increased renin hyperaldosteronism that you see that's very marked and very pronounced. And that's why early on in the formation of ascites, you see spironolactone being used because it gets into the kidney through glomerular filtration. It's not secreted via like an organic anion secretory pump like Lasix. So the use of aldactone has a very good response early on in the presence of ascites. When you develop refractory ascites and you have more of other neural immunomechanisms that are present with worsening splanchnic vasodilatation and vasoconstriction, these medications have less effect. If you think about the use of Lasix, it does help with ascites to a degree. Certainly, aldactone is going to be more potent. You do get more of a bang for your buck with Lasix if you have lower extremity edema, because it means there's fluid that can be mobilized from the interstitial to the intravascular space, because that's what Lasix does from a Starling curve hemodynamic. And again, looking at the chat, certainly this gentleman is developing worsening cirrhosis. If you look at the physical exam, there's sclerolicterus, and if the person has hyperbilirubinemia, that also can worsen the severity of AKI. This patient has, again, significant ascites, has markers of chronic liver disease, which we already know, mildly confused with asterixis like hepatic encephalopathy. And then the question is going to be, is there anything driving this process? Does he have SBP? Is there a GI bleeding? Is there another infectious process? What's causing the compensated to a decompensated state? And in a setting like this, always need to roll at SBP. anemia, GI bleeding, pneumonia, other infectious etiologies, and things like that. All right. Go ahead, Hans.
I don't know what else to add. I just ask myself, what could have tipped the liver to become decompensated, assuming that he does have a decompensated liver disease, and it looks like he does from the asterixis, the increased portal hypertension, the ascites, and the stigmata of liver disease. Is it possible that maybe the kidney somehow had an effect on the liver as a kind of a repercussion? It's just an open question I cannot yet answer.
I mean, you can't rule out that at this point he doesn't have worsening AKI that's causing the asterixis, and that this is a uremic process versus hepatic encephalopathy that's causing the, again, we need to get some lab work. And also, it's always important in the setting of liver disease to really know how to interpret a creatinine, because again, a creatinine is a measure of muscle mass. Someone with cirrhosis, they have disused muscle atrophy. They can have someone with a creatinine of 1, for example, and have stage 3, borderline stage 4 chronic kidney disease at baseline. There was I'm just a tangent real quick. There was someone who came into the hospital once, and this was about a decade ago. And the person presented had a creatinine of 0.7, and they presented with nausea and vomiting. And they were, of course, doing the workup. They had gotten GI to see the patient. They had done endoscopy, did everything else. They had consulted a nephrologist who was rounding at the time, and he said, do a 24-hour urine creatinine clearance and urea clearance. And the idea being that creatinine overestimates the degree of kidney function and urea will underestimate, so you take the average between the two. And it turned out that the average between the two was about 10 milliliters per minute. And the teaching point was that in someone with disused muscle atrophy, in someone with a creatinine of 0.7, they can still present with uremia. So I can't rule out, and Hans, you're right on point, cannot rule out a uremic component. Certainly, he can likely have a worsening AKI. When you're thinking about hepatorenal syndrome, it's often what is the etiologic agent that's causing the worsening of the kidney function. And again, you're looking for what's caused decompensated liver failure in this situation. SBP, GI bleeding from varices, pneumonia, infectious etiology, something like that. Even over-diuresis, although that's less likely here, because remember, metabolic alkalosis will change the ratio of ammonia to ammonium, and one of the causes of a worsening hepatic encephalopathy can be the development of a metabolic alkalosis. Again, less likely here in this patient who has resistant ascites and not really having much. I'm going to make the assumption of the diuresis with these diuretics. And if anything, if the patient is developing worsening AKI, we may be at the point on the Starling curve where you actually need to stop these diuretics because they may be maladaptive versus adaptive in this patient. I'm sorry, go ahead.
Amazing. Thank you for sharing all this wonderful discussion. We'll keep going for the lab. Moment. Okay, so WBC was 12K and hemoglobin 12, platelet count 72K, MCV is macrocytic, sodium was 131, chloride 93, potassium 4.5, BUN 40, creatine 3, bilirubin 2.9, alkaline phosphatase 150, AST 64, ALT is 53, INR 1.5, creatinine clearance was 28, pH was 7.2, PCO2 is 25, bicarbonate 14, lactate 1.9, ammonia is elevated, anion gap was 25, albumin 2.5, globulin 3.5, there was albumin globulin reversed, ferritin 665, B12 was low, procalcitonin was 0.7.
All right, Hans, you go first this time.
just repeat the labs one more time because we have platelet of 72, which is fairly low. We
At
have white blood
72,000.
72,000. Okay.
The low. I mean,
That is
it
very
is
low.
still
It's
low.
around
Yeah.
100,000 and more would be. And then we have hemoglobin. This is within normal range, although at the lower end, MCV macros. So we have sodium 131. We have a creatinine of 3, which points towards the liver, the kidney. And then of note would be the pH of 7.2, as I remember. So I think we would like to go with a arterial or venous blood gas to find out whether there is metabolic acidosis. And then we have high ammonia, which could probably be the explanation for the asterixis. So the question now is, what causes a high ammonia? And here again, we have the liver as one organ which metabolizes ammonia into urea, and the kidney, which by itself excretes ammonia and urea. At this point, I'm suspecting maybe as a possible insult, but this is only a hypothesis which needs to be shown, maybe an infection that could be underlying.
Do we have any prior labs in terms of what a baseline kidney function is? Like, do we have anything a month ago, or what is the heman? Do we have heman? I'm sorry, creatinine was 1. So it's gone from 1 to 3 in a period of time of a month, of a couple weeks. You know when that creatinine of 1 was from?
It was a little bit long time ago rotation, so I don't have that record. I'm so sorry.
Yeah, that's all right. So let's look at the labs real quick here. So creatinine is 3. And what I'm going to say is, I can't, certainly the ammonia level is elevated, but with a creatinine of 3 in this patient, this could still be uremic encephalopathy. Again, a creatinine of 1 in someone who's presenting like this, and I don't know their BMI, may represent stage 4 chronic kidney disease. So the creatinine of 3 could represent stage 5, or AKI on underlying stage 4 CKD, and this person could be uremic. So I would not rule out a uremia in this patient. Let's talk about the acid base for a second. So if you remember, patients early on with liver disease, they can actually have a chronic respiratory alkalosis. And the mechanism of that is, the ammonia, when it gets broken down, you do have increased chronic intracranial pressure that's increased. And, you can have some degree of like a vasogenic edema. Now, this patient does have an ammonia, has a high NI-GAP metabolic acidosis. If you look at Winner's formula, it's a compensated metabolic acidosis, pH is 7.2. Certainly, one could blame kidney disease for this. I would still go through the mud piles, although there is new mnemonics which have, I'd want to know things like acetaminophen exposure. I'd like to know things if there's any other exposure to other things you may have taken. Could this person possibly, I'd want to get a beta hydroxybutyrate. I'd want to know, could he possibly have like an alcoholic ketoacidosis? Is he drinking? I want to know an ammonia level, want to get an osmolality. So I would still want to do Goldmark. Thank you. So I'd still want to do, and go through that differential as well. Although I think this is likely worsening AKI. And again, the question is, what is causing decompensated liver disease? I'd like to get a procalcitonin level as well. The B12 is low. Is that ferritin 666 or 665?
665.
Okay, so that's, again, nonspecific inflammatory state with everything that's going on. So, at this point, in terms of one of the things that I would, I'd want to get a urinalysis. It's likely going to be benign, and I would like to get a urine sodium. In the setting of AKI, in the setting of liver disease, a urine sodium helps you and it doesn't help you. Let me explain. The 4 major causes of AKI in this patient right now One is going to be prerenal azotemia. The second is going to be ATN. The third is going to be hepatorenal syndrome. And the fourth, I'll get us, Yusuf, I'll talk about cystatin C in a second. And the fourth is going to be increased intra-abdominal pressure. So this is someone in the ER. I would likely be starting on intravenous albumin. I'd give a dose now because I'm going to suspect that this patient has SPP, has AKI. And again, we know that albumin has a morbidity and mortality benefit, but at the same time, also need to avoid volume overload by giving too much albumin. So the New England Journal article that's often cited talks about giving the 1 to 1.5 grams per kilo on day 1 and then on day 3. I usually tend to give albumin like 25 grams salt pork, BID. So I definitely, obviously, post-paracentesis, you're replacing for every liter that's lost, and this is just on a regular basis. You're giving 10 grams of intravenous albumin as a replacement. So this patient's got a blood pressure of 110/70. So if I'm seeing this patient in the ER, obviously I'm looking for a couple things. I'd want to get a diagnostic paracentesis and probably talk about a low volume therapeutic paracentesis. Why? If person has AKI, the last thing I want to do is take off 8 liters of fluid. And we've seen that done many times in the ER when you go to admit the patient and they've already had the paracentesis done. But a low volume paracentesis with the albumin replacement, you're getting the albumin in, but also if there's an aspect of increased intra-abdominal pressure, that's one thing you're going to rule out as a cause of AKI because you get a small percentage of patients that will have an increase in urine output. Getting a bladder scan and PVR on somebody with ascites is not going to be helpful because the bladder scan is pretty much going to show the ascites is present. Obviously, again, I'd want to rule out SPP in the patient and probably start antibiotics while I'm waiting for that to come back. In terms of management of the patient, I'm going, even if the patient, I'm not sure has hepatorenal syndrome as it is a diagnosis of exclusion, they still have hepatorenal physiology. So what I try to do is, again, once a patient has full-blown hepatorenal syndrome, many times when I'm seeing them, they are usually oliguric initially, especially if it's severe. So the goal is to try to prevent the degree of that acute insult affecting at least the way that I look at it, affecting the kidney. And in many of the early trials that they did with hepatorenal syndrome, they would wait till the patient had full-blown oliguria and then start treatment. I will tend to start the treatment on these patients in the emergency room. That's why I would give 1 dose of IV albumin. You're not going to cause that degree of fluid overload. They're likely going to get a diagnostic and therapeutic paracentesis in the ER. So I'd also start subcutaneous octreotide and usually I'll give 50 to 100 micrograms sub-Q Q8 hours. Again, that has an effect on the splanchnic affects the degree. It's kind of like a bridge between the splanchnic vasodilatation and the renal vasoconstriction, right? So it works as a somatostatin analog. And if I have a suspicion for possible varices, and I'm putting him on an octreotide infusion. The other thing is I'm looking at his blood pressure. Now, right now, do I think this person needs terlipressin, or if your hospital may not have it, I at least think a low dose of midodrine, an alpha agonist, would not be unreasonable here, like a 2.5 TID dosing. Why do I say that? When you think about the hemodynamics in someone with liver disease, one of the things that they can also lose is decreased SVR. So we talked about how the blood pressure medications, the diuretics, can be maladaptive. You can get worsening SVR, more hypotension, although a blood pressure 110/70, and they can still be preserved. But if the blood pressure was lower, I'd have a lower threshold to start on terlipressin in this person not coming in. Usually, one of differentiating, just looking at one of the questions in the chat, with pre-renal, they should respond either to a colloid or crystalloid challenge. Yes, you can have hepatorenal syndrome that is non-oliguric. But again, many of the cases that I see when they put the consult on, these are patients that have decreased urine output, but you still kind of go through everything. And the main difference is, yes, hepatorenal syndrome can, in terms of urine output, respond, but the difference will be pre-renal. You have improvement in your kidney function quicker than you will with hepatorenal syndrome. Many times the urine sodium is going to be low in all four states that we talked about: pre-renal azotemia, ATN, hepatorenal syndrome, and increased intra-abdominal pressure because of the degree of vasoconstriction. If I see a urine sodium that's less than 10, I'm rechecking that urine sodium over time, because sometimes my goals with therapy, I'm hoping to open up the kidney, increase urine output, and have more of a urine sodium. So for me, an increase in urine sodium level is a marker that the kidney function may be getting a little bit better, that there might be less vasoconstriction. If they don't do a low volume paracentesis, someone who's this tense obviously needs it because it may be affecting. And the other thing I'd be doing on this patient is I would be starting on a bicarbonate infusion, because I think, remember, your liver regenerates 80% of your bicarb, your kidney generates another 20%. So if you have liver cirrhosis, and that's why you likely have normal LFTs, because there just aren't hepatocytes, although surprisingly the patient still has synthetic function with an INR of 1.5. And then the kidney issue with regenerating the other 20% of bicarbonate, that's why I'm going to be starting on a bicarbonate infusion, in addition to intravenous albumin, subcutaneous octreotide, plus or minus midodrine, keeping in mind I may need a pressor. One of the other points, and then I'll stop, I apologize, I'm just going off it, but this just reminds me of so many patients that I've seen in the emergency room. My bias and my anchoring bias is I want to get them on the treatment before they develop the severe complications of significant hepatorenal syndrome, where they just stop peeing altogether. But one of the things that if their blood pressure, say, is in the 90s, one of the things that you need is to maintain renal perfusion pressure. So if this person goes up to the ICU, I'm going up to the ICU with him. It wouldn't be the first time I've walked with a patient up to the ICU, and I'm talking to the ICU doc, and I'm saying to them, I want to keep this patient on a low dose terlipressin, low dose levofed, with the goal of maintaining a systolic blood pressure 95 to 100. I want to go higher than an MAP of 65. Because you can have a blood pressure of like 88/60 and still have an MAP of 60 to 65. It may be lower than they normally are. I think these patients need a high, and I go by systolic blood pressure, at least, or an MAP of 70. And I'll ask them, please keep them on that dose for the next 24 hours to allow things, because once you're treating the acute process, you're treating the acute state. The process is whatever is causing the worsening of hepatorenal syndrome. You're treating the GI bleeding, you're treating the pneumonia, you're treating the SBP. Hopefully that decompensates over. The severity of how the kidney is affected decreases, because you're treating the acute process, but also minimizing the severity of the AKI with the octreotide, with the albumin. One of the things that I never understood with again, patients with hepatorenal syndrome, they are so sick and so ill that you can never really do a really good study to determine, because the mortality of these patients are so high. I tend to want to go for a higher MAP because the goal is to try to preserve kidney function. The data from Britain with terlipressin is wonderful, but not every hospital is going to have terlipressin, especially if you're working at a small community hospital. In many cases, even larger community health systems, there's ongoing debates about getting terlipressin on board. What I would say is I've used levofed and I like it, and I would do 4 to 5 mics per minute. It's just my own bias, again, maintaining a higher systolic blood pressure to avoid hypotension in these patients. Remember that your kidneys auto-regulate between blood pressures of 80 to 180 millimeters of mercury. Patients are coming in, they have systolic of 80, and then they have worsening renal vasoconstriction. The renal autoregulation is going to be even more messed up because of the splanchnic vasodilatation. And in addition, the severity of the AKI is worsening if they have hyperbilirubinemia. So again, that's why I want to maintain a little bit more perfusion pressure. I don't want to cause any more hypotension, because it just worsens vasoconstriction. Again, glomerular tubular balance, tubular glomerular feedback, hyperbilirubinemia causing worsening AKI, and that has really gotten me out of a lot of jams with patients who are, as Mark, you're absolutely right, these patients are extremely sick. I'm sorry, I went off on a tangent again. I'm sorry, Himon, go ahead.
Not at all. I mean, it's amazing learning. Thank you so much for great teaching. Yes, I will go for the UA. Actually, blood and urine culture were negative. Procalcitonin was done, it was 0.7, mildly elevated. And UA, blend sediment, no RBC, WBC, cast, proteinuria, or yeah, and then urine sodium was less than 10. FeNA was less than 1%. Urine osmolarity is more than 500. And the chest X-ray showed a mild effusion. Echo was normal. And you asked for ascites, right? Ascites PMM was more than 250. Total protein was less than 1. SSAZ was more than 1.1. And glucose was more than 50. And gram stain culture were negative.
So definitely meets neutrophilic criteria for SBP. And again, this is definitely cirrhosis because your total protein is 1. And again, that's always a board question. Why is it in CHF you have an elevated total protein more than 2.5, whereas with a cirrhosis it's less? And it's just because, again, you have sinusoidal fibrosis versus in a setting with CHF with a congestive hepatopathy, you have increased capillary permeability because of the increased pressures causing ascites. So again, with sinusoidal fibrosis, and especially with the large molecular weight of albumin of like, I think it's like 67,000 Dalton, something like that. It does not go, you're not seeing high albumin in the acidic fluid. Urine sodium is less than 10. Again, you need to rule out, I think, SBP, which we've done. So we definitely get intravenous antibiotics. So if you take a step back and you're saying, what are we doing for this patient? In terms of the AKI, we're looking for what caused decompensated cirrhosis in this patient, SBP, putting them on intravenous antibiotics. Remember the mortality, morbidity benefit with the intravenous albumin. You're starting that in the emergency room if they haven't started it already. I'm starting this patient on subcutaneous octreotide because I don't know which way he's going to head. Is there any reserve in the kidney? The creatinine is already 3. SBP causing worsening decompensated liver disease, causing the worsening AKI. I don't know if this patient is going to be oliguric or so I want to do a diagnostic paracentesis, a low volume paracentesis to reduce intra-abdominal pressure, see if that's playing a role. He's going to get the IV albumin that's going to, substitute for your colloid load in terms of, could this be possible pre-renal component? ATN versus hepatorenal, again, one is a physiologic process, one's actually a structural process, right? Hepatorenal is splanchnic vasodilatation, renal vasoconstriction. It can improve depending on the insult and if you get it soon enough. ATN is a structural process where, you're seeing granular chaos, you're actually seeing necrosis of the tubules itself. So it's a different process. But again, you can, in all those patients, you're going to see, low urine sodiums. Just like with diuretics and diuretic resistance, you can look at urine sodium. I look at how the urine sodiums do as these patients are treated. Initially, it's less than 10. As we're starting the treatment, he's getting the albumin, the octreotide, depressor, terlipressin or midodrine. Again, something that's an alpha agonist. Because I'm looking at the physiology of this patient. You have a cirrhotic patient, decreased SVR, then they have potential for sepsis, infection, decreasing SVR more. I just know endpoints when I've seen everything shut down and, no urine output. And then you're having the discussion about dialysis. Now, let's talk about that scenario for a second. Again, I apologize if I'm going off on tangents. It's like I can see this patient in the emergency room, and it's like the scenario just kind of repeats itself, in terms of what you have to pay attention to. If the person this person has a MELD of 30, so I'd want to know if this person has been evaluated by a transplant center. I would also want to have GI see the patient and get on the phone because this person has a MELD of 30. And then the question is, do they need to be evaluated by the transplant center itself? If the person is not felt to be a transplant candidate, dialysis is usually not part of the treatment plan because patients who are this sick never do that well with dialysis. They're not going to tolerate it. But obviously that's going to be part of your discussion when the person comes in as well, talking with the liver transplant team. Is this person a transplant? I mean, this person is a MELD of 30. That's pretty significant. Again, it goes from 0 to 40. But you mentioned at baseline, this patient has a child class of B. But so I'm going to make the assumption with a MELD of 30, this is a worsening, an MELD score of 30 being elevated because of the elevated creatinine. This person is not yet on dialysis. But you can see there's a lot that you're triaging in the ER. What's causing the AKI? How do I triage it? And then you're working the phones. You're talking to the ICU because if this person's blood pressure goes down, you want them to be on a pressor. You don't want to stop the pressor. This is my own bias, and there'll be other people that may disagree. But I've seen hepatorenal syndrome so severe where they're oliguric. Again, hepatorenal syndrome can be non-oliguric. My job is to prevent that from occurring if I can. This person's coming in with a creatinine of 3. So again, I know I'm repeating myself, but I'm thinking hepatorenal physiology may not have hepatorenal syndrome. But again, albumin challenge, low volume paracentesis, diagnostic paracentesis, 2-row at SBP, increased abdominal pressure, low volume paracentesis, you get a small percentage of patients that will urinate. You can't use bladder scan on none of those patients getting a bicarb drip. At least I'm starting with midodrine. One can make the argument the blood pressure is 110, may not need it. I'll give it a low dose of 2.5 TID. Why? Because of my own bias, and I will tell you what my bias is. I've seen these patients decompensate quickly. They get started on albumin because of the acidosis and the inability of the liver and the kidney to regenerate. I'm starting them on IV bicarbonate. The blood pressure goes down. Likely, I'm going to be starting them on a terlipressin infusion or a low dose Levofed infusion because it has a beta-1 effect as well, and acidosis certainly can have a negative inotropic effect, although that's arguable at a pH of 7.2. And my mind's going ahead of my mouth. I'm sorry. And again, you're watching this patient closely, at least PCO, if not ICU, given the severity of illness in this patient. And I'm, wanting to know, is this patient going to need hemodialysis? And I'm having a conversation with the transplant team in terms of whether or not he's a transplant candidate or not. The other aspect is, remember, repeat urine sodiums day 2, day 3 of hospitalization. The urine sodium level, if the kidney is getting less vasoconstricted, should improve. You should also see an increased urine output too. So, all right, go ahead, Hemon. I'm sorry, Hans. Go ahead.
Hans, do you have any? Do you have any? Yeah, I mean, Dr. Rich, you are awesome. You explained everything. Hans, do you have anything to say?
I think the go ahead. I'm sorry. I don't know if there's any more aliquots. Go ahead.
Yes, there's a last aliquot, and then maybe you can end it. I'll give you the last aliquot. Linear ultrasound showed no hydronephrosis or stone or masses. Fluid challenge with albumin and ceftriaxone started unsuccessfully. So it's HRS and midodrine and octreotide were started, and the patient was planned for liver transplant and hemodialysis. So diagnosis was hepatorenal syndrome.
The one thing that I listen to different podcasts, and even as a fellow, the management of hepatorenal syndrome in 10 years really hasn't changed. Again, these patients have a high mortality, but the two things that I would challenge you on, which I think is different from what you'll hear from other people, and again, this is my own bias, and I say that. All right, I just want to answer one thing in the chat. It used to be when I was a fellow, when dinosaurs roamed the earth, that a person had to be abstinent for 6 months before they would be evaluated for liver transplant. Now that's not the case, because what happened is, though while they're waiting for the 6 months, they had a high mortality rate. Many patients passed, so that's no longer an issue. It's kind of like, yes, they're being counseled, but they don't have to be abstinent for 6 months because of the high mortality rate. What I would say in this situation is, don't think about hepatorenal syndrome. Think about hepatorenal physiology. Think about that when these patients are coming in and they have AKI, when you think about someone with cirrhosis, a file should open up in your head. And you're thinking splanchnic vasodilatation, renal vasoconstriction, the severity of AKI in someone with cirrhosis is going to be higher than someone who doesn't, right? Not only because of the underlying pathophysiology, but again, hyperbilirubinemia. So again, you need a bilirubin of about 2 to 2.5 to be able to see icterus and jaundice. I'll get to the liver kidney transplant in a sec. The issue is going to be how long they have had abnormal kidney function for. If they've had abnormal kidney function, chronic kidney disease being more than 3 months, that would be the diagnosis to get them to a liver kidney transplant. In someone like this, you would need a little bit more data. Hepatorenal syndrome is, and again, is usually not enough for a combined liver kidney transplant, because when you transplant a healthy liver into someone with hepatorenal syndrome, in animal models, you cure the hepatorenal syndrome. Again, it's because of the splanchnic vasodilatation, nitrous oxide, things like that, which will trigger renal vasoconstriction. So it's thought to be more of a reversible phenomenon in that sense. But if there's chronic kidney disease that's been documented for more than 3 months, that's usually in which they're a candidate for liver kidney transplant. First, so the 2 major teaching points. 1, think about hepatorenal physiology in these patients. I'm not saying that they have hepatorenal syndrome, but that's why when someone comes into the emergency room, I'll give them the albumin, octreotide, and midodrine. The other aspect, don't forget the serial urine sodiums, because I have seen an improvement where you see like a urine sodium of 30 milliequivalents per liter, often corresponding to an increased urine output if there's going to be improvement in the hepatorenal syndrome. This was a very nice case. I'm glad. They talked with the transplant team, and he was started on hemodialysis. And on someone with hemodialysis with liver disease, it is very difficult. First off, albumin is not removed by hemodialysis. I'm sorry, ascites is not removed by hemodialysis. Second, they have such diminished reserve and decreased SVR, they get very hypotensive and don't tolerate any kind of fluid removal. Third, if there's anything else that worsens SVR, like sepsis, it is almost impossible to do dialysis. And then, of course, the bleeding complications from things like esophageal varices and things like that make dialysis very difficult. Someone asked about cystatin C. Cystatin C is, if you look at equations that are out there to evaluate someone's degree of chronic kidney disease. The most common, we started out with, the Levy equation, the different equations. The most common one that's out there now, that's the estimated GFR. It's actually a estimated. It's the chronic. Give me a second. Epidemiologic, CKD epi combination cystatin C equation to evaluate chronic kidney disease. Cystatin C is good in someone who has decreased muscle mass to evaluate. So you get someone who has stable kidney function with a creatinine of 1, cystatin C would be great. In the setting of AKI, less likely, but remember there are things that can adversely affect cystatin C production too. If someone has cancer cells increased production of cystatin C. If someone has increased weight, that can affect cystatin C production as well. And there's a list of other things, and even certain, I believe, medications which may affect cystatin C production. So that's always something I have to look up. So, but it's not. It is good in the setting of decreased muscle mass because it's readily filtered. It has minimal secretion, unlike creatinine, which has increased tubular secretion. As you have lower GFR, that's why it can overestimate kidney function. So, all right. I think, Yaz, I've maintained with less than an hour, so I think we're good.
No, I am impressed. I try to keep up with all the information, which is superb. I think that I can speak for everyone here that the pearls and the teaching are so good. So now we go with Paris to take it away with teaching points.
Dr. Rich, it was amazing. Thank you so much, and thank you, He, for presenting the case, and thank you, Hans, for co-discussing. We started with a patient who presented with abdominal distension, past medical history of the cirrhosis, and who presented with progressive abdominal distension. We learned that abdominal distension can result from fluid ascites. It is the accumulation of the fluid in the abdomen, and the level of the albumin in the fluid could helping us to differentiate of the causes. The other causes might be bowel obstruction or gas-related issues like ileus. We also discuss about the ascites and the renal causes. The presence of the ascites might be lead to increased intra-abdominal pressure, which are leading to decreased urine output, and it is one of the perirenal azotemia, which is highlights the one of the renal complication in the presence of the ascites. We also talk about when somebody is presenting with require frequent paracentesis in the context of the cirrhosis. We are usually thinking about worsening of a portal hypertension. This number is more than 30, and they are usually refractory to diuretics. And we know that something worsening is happening in the background. And even talking about pathophysiology, we know that some splenic vasodilation is happening, and it is leading to renal vasoconstriction. And generally, this condition might escalate the severity of the acute kidney injury, and that these patients usually require intervention like volume expansion or albumin administration to improve the urine output. But the thing it's really important here is differentiated with ATN and HRS, because the way we need to manage this different category of the patient. The initial therapeutic management is that administration of the diuretic. We usually start with aldoxone and Lasix. Dr. Rich told us that these two categories of the drugs targeting different mechanisms to manage fluid retention effectively. We also talk about potential condition in decompensated liver diseases like SPP, GI bleeding, and multiple infectious etiology. The other etiology in the background is overdiuresis of this patient, which is they are presenting with metabolic alkalosis and can change the balance between ammonia and ammonium, and this category of the patient are presenting with worsening hepatic encephalopathy. We also learned that early stage liver disease, the patient might be presenting with chronic respiratory alkalosis. We learned that acute liver disease and might have different renal presentation, like perirenal, ATN, HRS, and increased intra-abdominal pressure. And the urine sodium could be helping us when the urine sodium is less than 10 and the urine output is increasing. It is a one point that the renal is improving and there is a less vasoconstriction in the background. We also learned that the ATN usually is presenting with granular cast, but both of these conditions have low urine output. We also talk a lot about the management of the HRS, which it was filled with pearls and myths. We learned about this category of the patient should be managed, have diagnostic paracentesis, which is a low volume to reduce intra-abdominal pressure. We started this patient with IV albumin, which is reducing mortality and morbidity. We are doing bladder scan. We are starting octreotide subcutaneous to manage potential GI bleeding. We are starting vasopressor, alpha agonist, because we need to maintaining the MAP, and we might also start bicarbonate. At the end, we also learned that understanding hepatorenal pathophysiology is more crucial than diagnosis the HRS alone. Thank you so much, everyone.
Chris, hats off for those teaching points. This was superb. Dr. Rich, thank you so much again. Hans, superb presentation as always. And yeah, we will see you in the next Nephro VMR. Again, thank you so much for being here. Have a great rest of your evening.
Have a good one, guys.